Welcome back, everyone. It's nice to see you here. And my name is Dr. Kevin Zorn, founder director of BPH Canada, a dedicated institution to offer all men a wide variety of all the different BPH therapies, current as well as some part of clinical studies. So, just to sort of highlight, I guess it was a very, very animated discussion here on the preservation of ejaculatory functions with BPH treatments, sort of relooking at what we've uncovered in the last 5 or 10 years of the key elements for ejaculation, male ejaculation, which in the past has been something not talked about, heavily influenced or heavily affected, sometimes even permanently with some of our therapies, be it medical or surgical. So this was a state-of-the-art lecture I presented at this year's AUA in Las Vegas, and I'm here to kind of discuss it and jostle the mind of what was once thought to be part of the male health discussions, not always presented to our patients. So here are my disclosures. Once again, heavily involved with some of the BPH trials and clinical studies. And, it hasn't been that long as a mankind on this planet, and for that which we are here, and like in ancient times, the whole concept of a male ejaculation was looked upon as some elements of religious or philosophical or even some, early medical beliefs. The semen was looked upon as being maybe a substance of vitality and part of the spiritual well-being of a patient. Um, you know, Aristotle thought, the most perfect component of our food was something that was in there, and the whole element of a seed of a reproductive substance in the Parmenides. Some of the other elements of other ancient Greek views, intellect and reason, and the whole idea of seminal word as being sort of the active reason of fecundular matter. So the Taoist views is something of a vital life force, an essence of longevity and vitality. And some religious beliefs, the whole element of substance of the soul. And unfortunately, and I'm sure we've all heard some social and early views that masturbating or having other too much ejaculation could lead to certain various ailments such as blindness or what have you. So whether it was a taboo, you shouldn't be doing that. But the whole idea that this has come along in terms of the last few centuries, as various views on what seminal vesical fluid and what have you are for or are related to. And as of late, just the whole idea that there may be a protective effect. And there's been numerous studies that have looked at men with higher ejaculation frequency may have health benefits. And this could include lower risks of developing prostate cancer. So published in noteworthy journals that ejaculating more than 21 times in a month had a 19 to 22% reduced risk of prostate cancer. That was compared to those only having once a week kind of ejaculations, 4 to 7 a month. Others in of a Harvard University and Australian cohorts, there was again 4 to 6 to 7 ejaculations per week before the age of 70. Again, also had lower likelihood of having a cancer diagnosis. So clearly, there's some evidence that is pointing toward, the ability to release can have beneficial health, and at least in prostate cancer. We flushing away carcinogens or preventing buildup and reducing inflammation. There's some hormonal pathways that are not understood, but there's something there. So there's something to be said that there perhaps is part of the male health is important, not just for pleasure and for satisfaction, but perhaps there's an importance for health benefits. And looking at the actual act of ejaculation, what are the key elements? Is it a neurophysiological, the motor, the elements of fluid? We're in kindergarten. I mean, this is something that only in the last since the 70s have we actually scratched the surface to understand, much different and much later than perhaps the neurological pathways or the intestinal system. Ejaculation, we're still very young in our understanding, and this comes from some of the neuroanatomy, the electrophysiological, and some of the organ coordination, understanding the sequence of events that's needed to develop, a proper ejaculation. And we'll cover some of those. And if we go back and take a little pause, I think BPH surgery, what was our first surgery? It was, open simple prostatectomy. And this is like 1884. So, 140 years ago, where, the number one risk factor was mortality. There's a 1 out of 5 chance that you may not make it through surgery and have bleeding or other elements that and lead to mortality. So, that was where our first biggest informed consent, I guess, would come to play. And, this was around a time where most men, 1919, I believe, was where the year that the human race hit an average life expectancy of 50. And that's where we even start having discussions of PSA screenings. So certainly, there's been a shift toward a longer life expectancy of men living way past 70, 75, and into the octogenarian age group, where we're seeing a great deal more of men who are going to be having larger prostates and out of an age where they're looking more for their sexual function and ejaculatory preservation. So retrograde ejaculation with these techniques, over 80% will not be there. Next year will be our 100th year anniversary of Maximilian's invention of the TERP, first reporting out of New York. It is again, mortality was a big deal. Hemostasis was an issue. And so that was our first discussion of not even having the discussion of ejaculatory function, because we didn't quite know all about that at that point. So certainly that was higher incidence. And if we kind of look at what is normal ejaculation, what are the key elements that are in there? And you can see here most of it is seminal vesicle fluid, some of it's the prostatic fluids, very small amount of sperm, and then the rest from the vas deferens and bulbourethral glands. And there's 2 key messages here. Ejaculation is emission, expulsion. Let's talk about that. So, the movement from semen from the seminal vesicles of the prostate into the urethra is that emission. And that's, I think, something that's most impacted by alpha blockers, where we misnomer it to, hey, it's retrograde. Well, it's probably an ejaculation because you fail to squeeze, you fail to have emission. And for that reason, patients who've taken rapid flow describe, an ejaculation or an orgasm as kind of like having COPD and trying out to blow candles out on a birthday cake. It just seems very wimpy. You don't have that pelvic contraction. Very different than after a BPH surgery. And actually there is fluid that is either not coming out and because of a blocked duct system, or is going to the space and heading backward because of just this huge hole that we've created. So emission, again, that's that initial phase. And what we'll see on this is the from a cystoscopic view, that initial push out into that space. That's emission. And we'll cover some of the details that's needed for that. And that's, mediated through a, thoracolumbar process. It's the sympathetic elements that's going to lead to that contraction of some of those muscles, the bulbourethral glands, and provide what was thought once before the bladder neck closure, or is it the tissues just behind the vera montanum, which we'll get to. But ultimately, it's that reflex arc that initiates that, followed by the expulsion, which all guys, having an orgasm, it's going to involve 10 to 15 contractions, pelvic floor, at intervals of about 0.8 seconds. This is kind of like clockwork. It is a reflex. Once it's initiated, can't really stop it. And it leads to then that spinal reflex of pushing that fluid out of the body. And so for that reason, these are the 2 elements that are needed to get that. And that expulsion is the sacral reflexes that's going to create this, timed, mediated rhythmic contraction of the bulbocavernosus and the ischiocavernous muscles in sequence, leading to the fluid outside. And, bladder control closure, is that a thing now that we've seen with aquablation and a few other types of technologies? I don't think so. So I think we've come to realize what we once banked on is no longer. And there's maybe some other elements of closure behind the vera montana pericollicular tissue that lead to that. And why do we care about this? Why are we having this conversation? And, who cares about ejaculation? These patients are 70 years old, right? Why? They shouldn't matter. That they're not looking to have fertility. Is there a quality life element? Is there some questions of partner satisfaction? Um, is the industry telling us to do so, or as we said, are people learning about some of the potential health benefits and ultimately the satisfaction of the orgasm? And let's talk about that. So the force of the fluid coming out, the amount in the small study, well, it seemed to have significance in terms of satisfaction of the orgasm and the pleasure of the sexual activity. This is a publication we did, Dr. Bojani being the senior author, Dr. Bodana, and myself and a few others, Canadian team here, Dr. Elterman, looking at two groups of men, those who've had surgery, about 300 of them, and those who are going to have surgery, and what was important to them. In terms of the post-operative complications, what were they most fearful of? And you can see here in the different color schemes, there's sexual function, there's incontinence and pain. And that which was really, important was the preservation of sexual functions. You can see that there in the purple. And it was maintained even if you move to the right in those groups, 70 to 75 and even over 76 years old, at least that, 60 and 70-year-old men, the ejaculatory sexual function, very important, up there with pain. And I think that's something that needs to be said. So regardless of age, sexual function, very important to have a discussion. And part of our job as a urology society is to have that conversation. Not just here's your shim score for erections, here's your IPSS. Are you sexually active? How often? Is it important to you? How much has been impacted already? And what is their knowledge of ejaculation? Some people will kind of mix in sexual function as ejaculation versus libido, erectile, and then the orgasmic. So it's really important for us to take the time, maybe use other types of questionnaires looking at, the importance of not just yes or no from the MSHAQ. Is that important? And this is just another abstract that was highlighted and actually got one of the best posters for that conference section by the group Dr. Gonzalez and all, and kind of picking apart 7 different questions. You can see erectile function, bleeding, cost of surgery. What worries you the most? This was asked to about 1,000 men, considering surgery. You can see here across the board, the one that stood out the most was the preservation of ejaculatory and sexual function. So losing the ability to ejaculate was the biggest question. Above all those options you see there, ejaculation would be the most important. So this is a slide everyone pull out their phones. It was kind of like the Zorn update, kind of painting a picture of, it actually helps me when I counsel my patients. When patients will ask you, what's my risk of having ejaculatory dysfunction, loss of, across all BPH therapies, you can see here in the blue, all the resective techniques, the robotics, the hole-up, TERP, PVP, Greenlight. And again, there's a wide variety in the past. It just never was really reported in a lot of these publications because, again, it wasn't a highlight. IPSS, quality life, Qmax, PVR, but ejaculatory function wasn't one of the biggest clavy and dindo complications, but we have some series that have good reportings, and you can see there's some variability in the sequence. And one of the earliest 1970s techniques, the TUIP, was looked upon as being the first attempts to preserve ejaculation. So we just made these grooves, even unilateral, not bilateral, and had some reduction, some ability to lower that number for men, but still not great numbers, right? Not, there's the 1 out of 4, 1 out of 2 chance that it's gone. Then, 2013, Eurolift, every almost couple of years after, there's been a miss that's come into play. You can see them here in terms of that impact on ejaculatory dysfunction. And you can see they're quite low. And for the first time ever, aquablation kind of fits the resective, but has numbers, the single digit, close to, with regards to ejaculatory preservation. And that has been, I guess, a seminal moment that has kind of pushed us to understand it's no longer about the bladder. As we blow that thing open, those bladder necks are wide open. And you can see that. Look, the bladder neck's not there. And, I've had two patients thus far, two in my career of nearly 20 years now of doing BPH that I've had in the first year after surgery for BPH present me, like you see the aqua baby. They're pregnant. They got their wife pregnant within first couple of months after surgery, and we have a couple of spermograms to provide evidence that we're maintaining probably some reduction in volume because there's not as much prostate tissue, but there are sperm. They're able to procreate, and the ejaculatory function from water one, water two, as we know, uh, is knocked out of the park. This is something that just stands out, very different some of the technologies we've had in the past. I did another presentation just before looking at the water 2 data for these larger 80 to 150 and the water 3 comparative randomized study of HOLEP, THULEP versus aquablation. And that's that aqua water 3 study. And you can see here we've introduced thermal therapy using cautery, resecting more tissue down to get those vessels coagulating. And even with that, with more experience now, nearly a decade of technology and experience with aquablation, you can see the preservation of ejaculation actually went up a bit from 81 to 85%. Very different than enucleation. So for those doing enucleation, it's one of those discussions that you're going to lose your ejaculation forever. There is some people doing some modified techniques, but regardless, that superiority in preservation is substantial. All with the same IPSS changes between the technologies, and even though we're resecting a little less tissue, it's deliberately preserved for the benefits of the ejaculatory duct, which we'll get into, and the sphincter for incontinence. So again, there's a deliberate and purposeful preservation of that apical tissue that's not just for the sphincter and preventing the protecting buffer of tissue, but also the ejaculatory duct, the verumontanum, and all that tissue that's around the one rule. So 1 centimeter lateral, 1 centimeter on the other side of the verumontanum, and 1 centimeter back. That mound is where the duct will dive down. We want to preserve all of those for ejaculation. So I guess the whole idea, and we've done some further study of doing too deep of resection past the vero. So we actually set up our aqua beam and fire too deep, more than half centimeter below the vero cut. Chances are, this depth here, more than 5 millimeters beyond here, more likely will injure the duct system heading down to drain the seminal vesicles and other elements. So for that reason, you kind of break the road. The car can't get through to drive through the little tunnel to get out. So that's, I think, a big issue with lessons learned from the initial studies. And here we can see in the bottom left the butterfly cut where the oscillating beam is only going to be hitting between, let's say, 7 o'clock and 10 o'clock at a lower power. Then the robot will simply stop, advance, and do the same on the other side. And you can see here, there's our verumontanum. I think everyone in the audience will say, yep, that's the vero. But beyond that hole, do you guys know what the ductal system? How much of an angle it splays out? Does it go straight for a common duct? Does it splay? Nobody knows. So, I think, unless you're doing some kind of a retrograde for, ejaculatory duct obstruction for infertility, you won't necessarily see this in your planning. So if you don't see it, how are you going to preserve it? So, but there is an early branching and separation. So if you're going to be resecting and coagulating or lasering behind the vero, you still may get some of this retrograde ejaculation or anejaculation because you've fried the ductal systems. So you can see some, early anatomy of, different types of cadaveric series looking at the vero and what happens beyond that little hole. Where does the ducts go? How early does it splay? And this is sort of that rules of ones that come into play. And that role of the apical EG or ejaculatory hood is very important. I think we're going to dive into that now, what we understand when you do these procedures in that anatomic pathological study showing that 7.5 millimeters laterally, 1 centimeter proximal to the verumontanum is this network of this longitudinal muscle column, a group of kind of a hammock that from the bladder neck swings down, sits right beneath the ejaculatory duct. So again, just some orientation. You have your verumontanum with your ejaculatory hood here, and then beyond that, you're gonna have this duct system, kind of the main highway, the ejaculatory duct, and just behind it is this longitudinal muscular column that again acts like a hammock that will lift and contract, that will act like a piston of a gun that's going to help push things forward. So during an orgasm, there's going to be that initial longitudinal muscle that will contract, it shortens, and in doing so, it'll kind of act like a vacuum, pull in fluid out of the seminal vessels into the duct, swell, and then we'll get our next little phase of our emission. And so that's what we're going to be seeing, that shortening because of its contracture, kind of like, again, I use the idea of a water pistol where you're going to, simply pull, and that's going to create that generative force that's going to push out the fluid. And this is one of the videos from Gil Vermed and published, almost a couple of decades ago, with the idea that there's going to be that initial swelling, and there's that longitudinal muscle that's going to be contracting beneath, creating and orchestrating that elements of emission. And that whole element of ejaculatory hood preservation, as I mentioned, alluded earlier, laser techniques are trying to adopt this from green light. You can see that when you try and spare this, you take a centimeter back, if you're doing a TERP or so forth, and you don't have the aquablation. These are other ways, other techniques that you may be able to address the needs and wants of your patients without having to go out and get an aquablation. As I mentioned, only about 21 countries right now have access to aquablation. So the 196 countries on this planet, there's a lot that don't have aquablation. So if you don't, well, you can actually try and use these other techniques and PubMed the other types of ejaculatory hood sparing techniques, green light being one, hold up being another, and there's several others that have been published as well. So you can do it. Will you have the same outcomes as we see aquablation? It's hard to say, and I think a lot of it is anatomy in different patient populations, and not all men will get it because there may be some bad diabetics or people have other neuropathies that are out there that may also affect it. So help give men options. You got the mist, so if they're that's an option if they're really looking for maintaining their ejaculatory function, from Optilume to iTin to the resume technique. And if you're doing resume, you want to make sure, especially apically, you don't shoot too downwards. Some of that steam can get down, again, injure the duct systems behind the veil that you're not going to see. So there are some ejaculatory dysfunctions, and that some of it is the unpredictability of how the steam will disseminate throughout the tissues, especially at the apical area. So something to keep in mind for the younger patients. Looking at surgery, as we mentioned, aquablation, I think it's quite clear. But all those other types of resective, there are modifications which you can look into. And as sort of a thought leader in the BPH space and sort of my take-home message here, I think that we need to be innovative, and that we are as urologists in terms of surgical care. And it's been over the past century we've been more and more knowledgeable on those structures, as we've talked since the 1970s, neurophysiological studies of ejaculation. And beyond the vero, the orifice, is there other types of technologies that are going to help us in the recognition, so if we see it we can preserve it, right? I mean, like anything else, we know the vero is important, the butterfly cut does that, but think about all the other things we do in urology, right? You want to find a stone, it'd be heresy not to shoot up a retrograde urogram to see what kind of anatomy we're dealing with. Or if someone has a urethral stricture, we're going to shoot in some contrast, get an idea of the stricture length, width, and multiplicity. And up until 2018, this was our tool for BPH, right? And at that point, not even 7 years ago, we've pushed into the guidelines that we should, or we ought, if you're planning to do surgery for BPH, you should understand the anatomy. How big, how long, is there a middle lobe, bladder wall function? These are all things that I think are relatively new, but still we do that. So you cannot protect what you cannot see. So we kind of alluded to before, beyond the vero, what's the duct system look like? And when you do some infertility, you may get images like we see here on the bottom left. But where does that anatomy branch out? How long does it go? How deep down does it go? And when you're planning the butterfly cut, the angles, well, what do we know? And then it's a bit of a guesswork, and butterfly is mapped out to 1/3 of the length of your treatment zone. So it's computed by the computer, but if you can override it and map it out to that patient, that will allow us better abilities. And with the aquablation, you're dealing with the SUI ultrasound, which is, commercially merged with aquablation with a Procep. But imagine the day, especially if we're dealing with some of the prostate cancer with water 4, imagine having micro ultrasound, like the images you see here. You can pick up biopsy tracks. You can see granularly the ductal system. The anatomy is just phenomenal. So the higher ultrasound frequency and the granularity of the ultrasound, is impressive. And just like we saw at this past year's meetings, when you compare the micro ultrasound to MRI for prostate cancer detection, there's something to be said. So can you imagine a day where this ultrasound, which right now is really being pushed toward cancer and biopsies and what have you? Well, I think there's a lot more BPH than there is prostate cancer, and just in terms of sheer number of men we got to treat. I think that's something that we could be using more in the planning and treatment, and understanding and mapping out those important key structures of the longitudinal fiber ducts and the ejaculatory ducts. And finally, this is sort of the RVU, I call it. It's a technique I've been utilizing for the last couple of months with actually excellent outcomes. And I think I've only had one or two, so over 95% preservation of ejaculation. So I've cut down perhaps on another 10% of men who would have lost it had I not done what I'm going to show you here, which is beginning of the procedure, insert a small 5 French catheter into the verumontanum, and then during the mapping of the aquablation. So you can see here there's a 5 French catheter being, placed with flexible cystoscopy, then introducing the aquablation equipment. And then from that point, once I start, my planning of treatment, you'll see here on the right, the 5 French catheter will be introduced, and injecting water saline to create a distension, you can actually pick up the ejaculatory duct. So I can see where the verumontanum is on my cystoscope, but the duct system behind and in the tissue itself, you won't necessarily see. So I think that's a huge element of when I'm planning out the butterfly cut. Had I just taken what the robot would have pumped out, I would have nailed that ejaculatory duct. In not doing so, just if you can see it, you can protect it. So will we see other types of techniques of this retrograde verogram, be it with contrast or saline, other ways that is going to help us see that ejaculatory system to not injure it. So with that, that was the take-home message that I had. And sort of that whole idea of personalized surgical planning is a way of our future, be it with other types of visual equipment, diagnostics, or other types of finer ultrasound imaging. So, and here's just one of our patients with a spermogram who, with this technique, clearly is able to preserve, total sperm count. And this is just 2 months after this technique was performed during his aquablation. So take-home message, I think, number one, ejaculation is important, physiologically, biologically, men's sexual health. It's there. Men are living longer, wealthier, healthier, and sexual and ejaculation is an important part that we've underestimated. And once ejaculation damage occurs, most often it's unrecoverable. I've yet to see patients where they were not doing anything and then just coming out at perhaps after BPH regrowth, but that's kind of a one of few. Most often it's one of those ones they have to accept, and that's just the way it is. And there's not much in terms of our treatment that can restore that. So men with BPH who are sexually active, it's our job or duty, part of the informed consent. We gotta ask those questions. We gotta get in there to ask. Don't be shy. We got to include that in part of our notes as part of our BPH care. And missed of certainly, I think, by certainly all the people that are going to be listening on this are likely adopting at least one or two of these techniques, and that's one of our abilities to offer a therapy to maintain it. And most have less than a 10%, a single digit ejaculatory dysfunction, and some have zero, and we've covered those. And when surgery is indicated, if it's really important, they put that on their highlight. Aquablation does have that advantage superior to the other technologies, especially for larger prostates. and other types of techniques as we discussed for the hood preservation, especially the apex, just around the vero, the 1-1-1 rule. That should help you look more and understand from some of the references we had here. But future direction, I think using even more finer imaging, the prostate, the best, we've had ultrasound, then we have MRI, now we have PET PSMA, and what's next? I mean, it's just an evolution. It's beautiful to watch. I'm sure we're going to be seeing some more stuff in the future, but our ability to see, we can protect, we can preserve it. We can see cancer, we can nail it, we can treat it. That's where we're at in prostate. So I think my prediction in the next 5-10 years, we're going to be seeing some newer imaging technology that's going to get us there. The interest is there, and as we're innovative, and this is just some of the innovative stuff we've learned in the last 50 years, understanding ejaculation, and more to come. So thank you for your attention. I hope this was entertaining and educational, and please see some of our other videos if you're interested. And if you're also interested, come visit us at bphcanada.com and see some of the cool stuff that we're doing at our site. Have a great day and have a safe summer.